Our second speaker is Dr. Loretta Lee Grumbles, and she's an assistant professor here in geriatrics. Dr. Grumbles is new to our department and is already making a huge impact on education, especially related to palliative care, and is working with a grant, Arthur Vining Davis Foundation grant, providing DVD education through DVD development on palliative care and life issues. It's a very good project. Dr. Grumbles was born in Abilene, Texas, and she's in West Texas, and she's proud of it. She received her medical degree at UTMB in '97 and a residency program with internal medicine between '97 and 2000. She received UTMB's award for the Primary Care Resident of the Year in 2000 and spent 1 year in private practice as a general internist. But her practice concentrated on the frail, elderly, and the terminally ill. She was recruited to UTMB Department of Internal Medicine in the fall of 2001 and joined the hospice care team as medical advisor in the fall of 2003. She established palliative medicine selectives for the UTMB MS3 and 4 programs and is currently providing palliative medicine education for the family medicine residency program. She anticipates starting an inpatient palliative medicine consult service in late 2005 and early 2006. Her topic is palliative care. Do you pronounce it palliative or palliative? Dr. Grumbles.
Well, I'd like to take just a second to tell you a little bit about me because I think it's very important for the audience to get to know the speaker. And then I'm going to ask y'all a few questions to help me get to know you. I'm 48 years old, and medicine is a second career for me. I didn't start medical school until I was 36. I spent 20 years as a registered respiratory therapist before I became a physician. So I looked at end of life, I look at interdisciplinary team, and I look at the practice of medicine a little different than what most physicians are going to look at because of my past experience. So it was a natural progression for me to make a decision. I either wanted to be a critical care interventionalist or I wanted to be a palliative medicine physician. And I think I made the correct choice for me by seeing my past experience to be best used in moving into palliative medicine. Now, I'm going to broach some on what Cheryl Viana talked to you about today. And I want to take a quick exercise by just doing a survey by show of hands, and I want you to answer some questions for me right quick so I can get to know you as an audience. How many of y'all have talked to a colleague, a working colleague, about your desires and wishes for fear of death and dying, or for your desires of how you want to die? Raise a hand. Good number of people. How many people have talked to your spouse, your significant other, or someone that you think is going to be at your bedside seriously about what you want for your end of life? Still lost a few, but still have a pretty good number. How many of you have bothered to get off your tushy and fill out your advance directive and take it to your physician? A lot of fallout, a lot of fallout. Well, we're going to talk a little bit about palliative care, and then I'm going to try to convince you that it's time for you to get off your tush and do something. Now, the title of this comes from, do you pronounce it palliative or palliative? I wear this button for the past 18 months since I decided that I was going to do palliative medicine. And it says, ask me about palliative care. Well, the one most common question I get, whether it be lay people in the hallways, nurses on the floor, or my fellow colleague doctors is, do you pronounce it palliative or palliative? Well, I actually got the question asked so much that I went to Webster's and looked it up to make sure I was right, and it's palliative with a short A. So we've cleared that up. Let's go on and talk a little bit about what it is now. Our objectives today are going to be very easy. We're just going to define what palliative care is. We're going to describe the current state of dying in America, which Cheryl's already talked about a little bit. We're going to contrast this with the way Americans have expressed through survey their wish to die. And then we're going to self-reflect a little bit on how you wish to die and maybe prompt you to go get those forms of advance directives and take the step forward to ensuring that your wishes are carried out. I start all my palliative medicine lectures with this little cartoon. And as I told you, I'm 48, so it's beginning to mean something to me. But it says, one thing about getting old, it takes dying young out of the equation. Now let's start with a definition of palliative care. The Institute of Medicine in 1998 said palliative care seeks to prevent, relieve, reduce, or soothe the symptoms of disease or disorder without affecting a cure. Now let's stop right there before we read on. Did anybody hear me use the term irreversible disease? Or what about end of life? Or the D word, death? Or dying? No. The definition said it seeks to prevent, relieve, reduce, or soothe the symptoms of disease and disorder without affecting a cure. So palliative care in this broad sense is not restricted to those that are dying or in hospice programs. It's a practice of medicine for all physicians to integrate in their scope of practice. It attends very closely to the emotional, the spiritual, and the practical needs and goals of patients and those close to them. So the three things I want to make sure you get out of the definition of palliative care is that, one, you don't have to be dying for a doctor to practice palliative medicine on you. Two, you don't have to have a life-threatening disease that's making you have horrible symptoms. And lastly, palliative medicine considers not just yourself and your physical state, but your family and your family's emotional, spiritual, and social state. Now, I'm going to give you two case studies. These are kind of hypotheoretical. Some of them, bits and pieces are real, and bits and pieces are kind of created to get the educational effect. I had two 50-year-old men come to my office with no previous health problems. No, they didn't smoke, weren't on any medicines, had been very healthy. Both of them had developed fevers up to about 102, had started coughing over the last couple of days, a little bit of yellow blood-streaked secretions, and their wives were so tired of them complaining about how bad they felt and how they didn't have an appetite that they drug them to my office. Now, one of them's in room A and one of them's in room B. I go in and get the history of present illness, and it's both the same. They've been sick for a couple of days with exactly the same symptoms. I do a physical exam. They both have crackles in their right lower lung, and I'm thinking they probably have pneumonia. So I get a chest x-ray. Sure enough, both of them have right lower lobe consolidations. They have a community-acquired pneumonia. Well, they're both healthy men, not excessively up in age, non-smokers, no heart, lung disease, so they both qualify to be treated with outpatient antibiotics in the home setting. So my plan of care medically for their physical problem is write them a prescription for antibiotics, instruct them how to take Tylenol for symptom control, tell them to get some rest and stay off work for a while, and tell their wife to push as much fluids as she can down them for the next few days. Pretty straightforward. Going into room A, I flip through the chart and see on the social history that the patient in room A is an executive at the insurance company down the street. And he has good insurance that I know pays well, similar to mine. So I go into the room and I asked him, I said, you know, I'm going to give you some antibiotics, but I need you to stay off work for a while. Is that going to present a problem? No, I've got 7 weeks of sick time saved up since I've been at the company. And besides that, I got 3 weeks of vacation left that I haven't taken out of my 5 weeks of vacation time. No problem. I said, okay, I'm going to give you some prescription. Do you have a drug prescription benefit with your insurance? Oh yeah, anything you write for will cost me $45 or less. No problem, doctor. I write everything out, give him his instructions, say my nurse or I'll call you tomorrow afternoon, make sure you're doing okay, call me if you get any worse. Send him on his way. Didn't practice much palliative medicine in that situation. It was primarily curative. I go into room B. When I walk into room B, I say the same spiel, and I say, you're going to have to stay off work for a few days, get some rest. And him and his wife looked down, devastated. And I said, you know, tell me what you're feeling right now. You look so despondent and upset with that statement to stay home and rest for a while. The patient looks to his wife. She starts crying, and he looks back to me. And he said, I'm a landscape engineer. And I thought, ooh, that sounds pretty good. I need him at my house. And then he said, do you know what that really is? And I said, you design flower beds and landscape? He said, I'm a one-man self-employed show. He said, I mow people's lawns, and I put out mulch under their trees, and we live from paycheck to paycheck off my weekly checks that these people write to me for mowing their lawns. He said, if I'm out a week, we're not going to be able to pay the electric bill. And then he looks to his wife, and she's crying. And he said, you know, honey, I'm sorry. We just got caught up. She'd had a baby 18 months ago, which was a surprise without insurance, and they had just managed to financially get that paid up and get out of that debt. And here I was hitting them with something else. Well, I had to validate this patient's feelings. You know, there's no way I can facilitate him having another job that has vacation or sick time for him to take. But I validated. I say, I can see this is devastating you financially. You know, I can see you're very upset with this. Let me try to help. I will try to see if I can have some sample antibiotics in my closet, and if I don't, I'll write you a prescription for the cheapest antibiotics I think we can get by with. And don't worry about a follow-up appointment. I'll just call you a couple of times over this next week, and as long as you're not getting any worse, you don't need to come back and see me for a repeat chest x-ray and to get any follow-up care. Folks, that was palliative medicine. One thing that physicians many times don't think about as palliative medicine is just taking the time to look at a patient suffering from something other than their physical symptoms. That landscape engineer was suffering from his financial, social distress just as much or more than he was from his cough and fever and anorexia. But it took a physician a moment to step back and look at the person on multiple levels to realize that there was something going on rather than a community-acquired pneumonia. The broad sense of palliative medicine covers that as palliative medicine. I attended to a suffering he was having that was being impacted by his disease, but at the same time I was addressing it on a non-medical level. I addressed it on a social level and included his wife in it. That's all the definition of palliative medicine is. So physicians should be practicing palliative medicine regularly. I think most of you would say, I sure hope my primary care doctor is practicing palliative medicine, because I think everyone would want to be treated that way. One of the things, though, is people think palliative medicine is a new science. We had the American Board of Hospice and Palliative Medicine incorporated in 1995. And in January 2005, there were 1,900 board-certified palliative medicine specialists, or I call them specialists, certified physicians. We haven't been given subspecialty classification as of yet, but we feel like that'll probably be coming in the next year or two. But the point is, everybody thinks this is new, something new, fancy, because it's a new certification and it's a new buzzword in hospitals. It's not a new science. It's a group of doctors that are very adamant that they need to practice the old art. And the old art was being a good communicator, which means active listening, good verbal communication skills, and able to express and respond with empathy to a patient. That's primarily what a palliative medicine doctor does. Yeah, we have our drugs and our triplicate narcotics, and sometimes we have a few interventional tricks that we can use to relieve pain and suffering. But the majority of our job is not to relieve physical pain. It's to make sure that someone is addressing the other types of pain which comes from social, emotional, or spiritual suffering. Now, Cheryl's already broached on this too from Dr. Castle's article statement, and that's the objectives of the practice of medicine. What is it that doctors are supposed to do? Well, they're supposed to relieve suffering, promote health, prevent disease, and diagnosis and cure things. Well, folks, if I took every article that those 4 objectives have been published in, there's 3 that start with relief of suffering. In all the other articles, relief of suffering is listed last. So what we do is we imply to people that relief of suffering is not quite as important as diagnosis and cure of disease. Now, since I'm a palliative medicine person, and I usually speak towards people that are interested in palliative medicine, I'm always going to put relief of suffering as the first on my list. But you look in the literature, rarely is that ever done. Now, why has that happened? Well, medical education concentrates its training on diagnosis and treatment of disease. We spend 95% of our time teaching our residents and our medical students how to diagnose and treat disease. We do 2 to 3% of the time treating health promotion and disease prevention. And we probably spend 1% of the time teaching people how to relieve symptoms. We assume that they will learn it ad hoc on the floor as they work with patients. And I must tell you that the people sitting in this room, the nurses, the physical therapists, the occupational therapists, the respiratory therapists, those are the people that teach doctors how to relieve suffering, because they're not getting it in their medical education. They're getting it from what you on the floors teach them that you've seen, that works, and they try it. So we minimize that training on relief of suffering. And that's one of the reasons why we have to be careful when we choose doctors and our patients choose doctors. Are you sure your doctor's skill and philosophy matches how your patients want to be cared for? Primarily be cared for in the future, because most of us choose a doctor when we're young and healthy and we don't need him, and what his philosophy and skills aren't going to make that big a difference. But as we get older or we start developing diseases, that becomes very, very important. Now, let's take a quick look about how Americans died. Let's switch. I've told you how palliative medicine is not always related to death and dying. But a big part of our job, the majority of our job, it really is when you deal with the specialty area that I deal with. So let's talk about how Americans died in the past, in the early 1900s. Well, the average life expectancy was 50 years old. So most people stayed fairly healthy till 45 or 50, and usually by the time they got to 50, there was some accidental death, acute rapid illness. If you think about it, cancer was not a big problem back in the 1900s because we didn't live long enough to get a massive population of people developing cancer. So we died young. Our childhood mortality rate was high. We lost lots of infants and lots of children early in life that never got a chance to grow up and even hit that 50-year-old mark. Really a difference now is my geriatric practice. I see my elder patients. My average age in my geriatric clinic is 86. I have 2 that are above 100 years old, one of which is still living by herself, taking care of herself at 101. But back then, older adults were considered elders once they hit about 60. Prior to antibiotics, death was quick. You either died from an accident or you got an acute infection and died in a matter of days. And the physicians and healthcare providers focused on caring and comfort because they didn't have any cures or ability to make definitive diagnoses. They cared about how the patient's suffering and tried to relieve the suffering. And the sick, they weren't sent to hospitals, they were cared for in the home. And if you were dying, you sure didn't die in a hospital, you died in your own bed in your home. Well, since 1900, science and technology has shifted medicine's focus. What has happened is we have rapidly developed science and technology avenues that allow us to diagnose and treat many diseases. And as we've done that, we've changed medical education. In the early 1900s, we were worried about how we were going to relieve pain with morphine, making sure doctors knew how to do that. Now, we're worried about teaching doctors how to order the MRI and read and interpret the MRI. We have the knowledge and skill to fight aggressively against most any illness and aggressively against death. And one thing we've really gotten good at is prolonging life. Now, something that I have a problem with is I don't have a problem with prolonging life. I'm all for that. I love my 101-year-old lady who's living alone and taking care of herself. You know, God bless her. But at what cost do I prolong other people's lives? And in medical education, we've come to the point where we are teaching our young doctors to prolong life at all cost. Many times when we get a plan of care for a patient on the wards with an irreversible and usually already diagnosed terminal disease, my residents write out their possible care plan. And it starts, number one, as the most aggressive thing we could do, even though it might not be a positive outcome for the patient. And the last alternative and option on the list is the palliative medicine approach. So we have actually shifted our physicians' mind thoughts. We tell them death is the enemy. And what do we do if someone dies? We've failed. A physician's failed. They really and truly feel a sense of failure to their patients when their patients die. So seeing what we've done with our education and our science and technology advance, let's talk about now about how people die in 2004. We said they were young. They usually died in acute, quick death. How do we do it now? Well, there's much difference in our cure rate. We still only have a few cures, probably not many more than what we had back in the early 1900s. So what we do is we have ways to stabilize chronic diseases and prolong life, which is the difference between the early 1900s and now. We live much longer with chronic disease. Before, if you were a diabetic, severe hypertensive person, you would die very quickly within just a matter of a few years at the most. These are diseases now that are controlled for 3/4 to 50% of most people's entire lifetime with medical intervention. And we've prolonged the dying process. I told you when people got sick, maybe they'd get sick from a bad pneumonia or an infected wound or some type of accident, and they would usually die within a few days. Now our dying process is extended from days to weeks, and most of that dying process can even be included in hospital stays. Now, less than 10% of the people that die in America nowadays die of an unexpected death. They're healthy, they're doing fine, they're active, and then at one point in the moment, they have a heart attack, a bus hits them, or they're playing basketball on the basketball court and they have a life-threatening arrhythmia. Less than 10% die that way. A bigger percent, and I'm not actually sure on the percentages on this, but it's going to be somewhere around 40 to 55%, will die from a life-threatening illness with a steady decline. This is due to our cancer patients. Most of our cancer patients will have this type of decline. And the only thing that we can possibly do to change this decline usually is we can change the slope. We don't change or cause a plateau. We usually just change the slope and extend the time that the person lives with the disease and slows down the onset of symptoms and health status decline. But the one that I really trouble with and have difficulty in palliative medicine handling and stabilizing is the patients that have the chronic illnesses that I have taken care of for years and years and years, and they have declined very slowly, insidiously over years, until their health status is no longer up here. Their health status is only at 50–60% of a normal health status. And they're continuing to decline on down. But what I see is they exacerbate. These are our dilated cardiomyopathy patients with CHF that come in and out of the hospital regularly. Your COPD patients with end-stage COPD that are in or out of the hospital. If you notice, there's a lot of suffering going on here. There's a lot of time that's spent really down here in the dumps as far as getting close to the death. And as we become better at prolonging life and controlling these chronic diseases, we have more and more people that are moving into this realm of patient care. Now you've seen the 3 ways that people normally die in America. Do we die the way we wish to die? Well, in the 90s, the Gallup poll survey said 90% of people in America wanted to die at home. They didn't want to die in an institution. But still, as of the 2000 statistics, 75% of Americans die in institutions. Now, granted, 25% of the patients are dying in a nursing home type situation, which many could make an argument that that is a home situation. And I myself feel very strongly that a nursing home can definitely be a home situation for a patient. But still, that leaves us with 50% of patients who want to die at home, dying in a hospital. Now, could we get these people home that wish to die? Could we let them die at home? When we look back at studies, we see that the majority of institutional deaths could be cared for at home. Symptoms could be controlled in the home. Patient care could be given adequately in the home. There are, in some palliative medicine and hospice care, there are some deaths that we cannot make comfortable in the home setting. And we have to have the option to move to the hospital to allow us to aggressively control and manage symptoms and suffering. But that is a rare few cases that would require institutionalization to take care of the suffering. Most of the time, the amount of care the patient needs can be done in the home setting. So you see, there's going to be wide gaps between what Americans say they want and what's actually happening. Another study looked at the fears and desires of Americans. One fear was that they had a fear that they were going to die on life support. Another, that they were going to die being uncomfortable and suffering. A third was that they felt they were concerned when they're dying they'd be a burden to their loved one. And lastly, they feared they would die in an institution instead of home. Well, on the flip side, they asked people what it is that you desire. How do you desire to die? What is your, as Cheryl put, your fantasy death? Well, a big deal is they don't want to die on a ventilator. We have stigmatized ventilators to where ventilators are just unacceptable to most people. You know, put them in the ICU and you can run all the Levophed and epinephrine you want through their veins and flog their heart, but don't put them on a ventilator. We have just stigmatized mechanical ventilation. So it's something that Americans see as very negative in the death process. Another is they all want to die in comfort. They don't want to suffer. They want to die with their family and friends around them. They don't want to be a burden, but they don't want the isolation of dying alone. They fear dying alone. and most of them want to die at home. Well, let me tell you a little self-reflective story now. In 1986, I was one of the chosen registered respiratory therapists that received a survey, a study survey, from the American Association of Respiratory Care. They wanted to evaluate the attitudes, beliefs, and values of the registered respiratory therapists that they felt were intimately working with end-of-life patients in the critical care units. They wanted to know what we thought about different things, and then they also wanted to know what steps we had taken to make our wishes known. So they asked a bunch of questions about what was quality of life to us and, what we thought life support was and wasn't. And then they got to a group of questions that said, have you ever talked to a colleague and expressed to them your wishes for how you would like to die? And I said, yes. And then it said, have you ever talked to a significant other or your spouse or a family member that would likely be at your bedside during your death and seriously talk to them about how you would want to die? And it was, I complain about all this that goes on to my husband when I come in every evening, how frustrated this or that was, but no, I've never really had a serious conversation. I have to answer no. And then it said, have you filled out an advance directive? I had to say, no. And then I sent my survey in thinking, oh my God, I'm going to be the only person that is flunking this survey. Well, I was privy to the preliminary data. 85% of respiratory therapists adamantly said they did not want to be put on life support of any kind if they had an irreversible and terminal disease. And their definition of irreversible and terminal was actually a lot more lenient than what most people use now as definitions. But 85% of them did not have an advance directive. That got me off my tushy. And I wrote an advance directive. And because I didn't like the way the advance directive was written, I added my own personal comments. And so now when I turn my advance directive, which has been amended 2 or 3 times, over to my PCPs, they refer to it as Lee's Death Manifesto. Because I have to communicate. If I can't verbally or communicate in writing or verbally, I'm sorry, that's not quality of life, and that's not really addressed in the advance directive. So I have these long paragraphs explaining what I think quality of life is so that no one can misinterpret what my wishes are. But the fact of the matter is I got scared. The people that I was sure would be aggressive about taking care of that type of thing, and I was just the outlier, I found I was the norm. And I decided I wasn't going to be the norm. I was going to make sure that I did what I needed to do. So I filled out my advance directives. The only way that you can close that gap between what your fears of dying are and what your desire and how you want to die is to communicate. You have to fill out the forms. You have to talk to your loved ones that you think would be present at that time of your death and care enough to be at your bedside. And you have to talk openly with your doctor. Now, as a physician, I can tell you, I am one of the rare physicians that when you sit in my office, I'm going to bring the topic up. You have to bring the topic up. You need to bring your piece of papers into your doctor and say, I have my copy of my advance directives, and this visit is not to check my blood pressure, not to check my diabetes, not for my pap smear. It is to talk about my end-of-life issues so I feel comfortable that you're going to care for me in the way I wish to be cared for. Now, I always close my palliative medicine lectures with this. I love this. This is a real tombstone in a cemetery. That is a Polish name pronounced Imsik. And I think it's so cute. It's, I told you I was sick. How many patients tell us over and over, I told you I was sick? Well, this guy meant it when he told his doctor he was sick. Okay, open for any questions?
You know, I just have a comment. You said about, taking your advance directives to your doctor. I had a procedure done here where I had to have an anesthesia, and I told the nurse, I said, you know, I have my advance directives with me. Well, nobody was interested. I mean, it should be every
Yes.
encounter with the healthcare provider. That's what PSDA says.
Yes.
And how come we're not doing it?
And you well, I'm working to change the culture here at UTMB, but until I make any headway, you need to just keep that piece of paper and say, I want you to note this piece of paper and go put a copy in the front of my chart for me right now. You're going to have to fight your battle on your own for a while until I can make some headway against the culture.
I think in general, people think palliative care in terms of pain management. That's when I hear that's the first thing I think. And so that's kind of what's trying to change, to go away from pain management, obviously being important, but going to the non-pain social.
Suffering management is the term I use with my residents and medical students, is that we need to address suffering management, not pain management.
Any questions, comments here? SFA? Any comments or questions for Dr. Drummond?
No.
No.
All right. Okay. Lamar? Very good. Thank you.